Okay. Welcome, everybody. Thrilled to be back with you tonight with our talented host, Glenn Grossman. I am Rebecca Berman, thrilled to moderate tonight. It is February 14th. Happy Valentine's Day, sending all of our love to you. And really, this community that we've built together has been just so powerful, I know for me and so many of us during this time together. And Glenn, we just can't say it enough. So I'm just going to say it again, how much we love you, especially on this Valentine's Day and always.
Likewise, thank you.
Are our tour guide extraordinaire. And we really appreciate you telling us the way it is, the good news, the bad news. You've kept us current throughout this whole experience, and we are so incredibly grateful. So, as we know, Glenn Grossman is an epidemiologist with over 20 years of experience. While pursuing his doctorate in epidemiology at UNC Chapel Hill, Glenn served as an epidemiologist on staff at the UNC Infectious Disease Clinic for 2 years and taught epidemiology and advanced analytics at Duke Medical School and at UNC. He has been involved in epidemiology forecasting and advanced analytics with Bristol Myers Squibb, Sanofi, Novartis, Medicare, Medicaid, Veterans Health Administration, the Military Health Service, CDC, and other programs within the United States and abroad. All views expressed today are his own. Okay, Glenn, we'll kick it off like we usually do. Please take us around the country and take us around the world, and then we will zoom into all of the questions that this audience has really been terrific in providing during the week. And feel free to jump in if you have questions that come up during our conversation. Please send them to me privately through the chat box, and I will do my very best to work them into our conversation.
Thanks, Rebecca. Thanks, everyone. All right, let me share my screen and let's just jump right in. All right, so where are we? At this point, around 1 out of every 12 people in the United States has been infected with COVID-19, according to the CDC's tracker. So this is, let's call it, instead of infection, let's say diagnosed. Around 1 of every 12 people in the US has been diagnosed with COVID-19. And so then when we look at deaths, 1 out of every 715 people in the US has died of COVID-19 in the last year. When we look at the restrictions that are currently in place, there's only a few states with some level of stay-at-home orders or advisories. Some businesses are still closed. There's more advisories in some other states, and mask wearing is still not universal. There's a federal requirement, but within the states, there's a lot of states that still do not have universal mask requirements. Let me go now to, not this one. All right, so here is, here is the world at a glance. So this is the total new cases. So this is telling us where the outbreaks are. In fact, I can make this a little bit bigger. Where the outbreaks are around the world. The darker the color, the bigger the outbreak currently. So you can see that in Eastern Europe, there are some more cases in some countries where there's some outbreaks. Estonia looks like it's a little bit darker right now. Czechia, you can see some of these. Slovenia is still an outbreak, whereas UK has been on lockdown, so they're going down. But you can still see that there's a lot of countries around the world that are an active outbreak. Surprisingly, South America, where it's southern, so it's the southern hemisphere, so it's currently summertime there. There's still outbreaks, and this is largely because of the increasingly spreading variant. And so we'll talk about that in a little while. You can see Australia continues to do really, really well. When we look at cumulative, you can see that some countries have been hit really hard, the United States among them, but other countries too have been hit really hard. And so let's go now into vaccinations. So vaccinations are only one strategy to really address COVID-19, because we really should be doing the wet mask wearing. You can see, so for instance, when we went back to Australia, this was cumulative. You see that Australia has not had many cases relative to the size of their population. And that's not because of vaccines, that's because of their mask wearing, the physical distancing, other constraints that they put in place to prevent these outbreaks. And so some countries have been doing well, but the vaccines have had nothing to do with it so far. When we look over here at the vaccines by country, so definitely the global leader right now is Israel. Israel has around 73% of its entire population has been vaccinated at this point. United Arab Emirates is coming in as a second, they're around 50%. Then United Kingdom, they're racing to get people vaccinated right now because of the UK variant. So they've really made this a priority. And then you can see after that to the United States, we're a little over 14%, between 14 and 15% now. Oh no, we're over 15%. Let me make it a little clearer. All right, so yeah, Israel is a little over 15% at this point. Next is Chile. You can see European Union on average is lower, and it goes down. The world average is still slightly above 2%. So we have a lot more to do. It's going to be really critical for us to vaccinate the rest of the world because that's where these new variants are going to be continuing to evolve. Because people who are not vaccinated will continue to get infected, and then can get these new variants can then come back into the United States, come back into Europe and these other countries. So we really need to ensure that we get the world vaccinated here. All right, that was, I think, all I was going to look at there. Within the United States, you can see that there's a clear trend down. Our hospitalizations have been going way down. We're still not out of the woods by any sense of the word or the term. You can see that we still have almost the same number of 9/11 deaths every single day in the United States. It's not quite as bad as it was a couple of weeks ago, a month ago, where we were hitting 3,300 deaths a day easily. However, the fact that we're still having the equivalent of 6 9/11s every single week we're not out of the woods. There are many people dying. We're at a far higher number than we were at the peak of the first surge when we had the lockdown in March and April. So we still have, it's real, and this is something that we could end pretty quickly if we just had a shutdown for a couple of weeks, or had universal mask wearing or other kinds of things. I understand that there's political constraints, but if we did have stimulus funding, for instance, that went out to those at highest risk, then being able to shut it down for 2 weeks would save over 100,000 lives within the next few months potentially. So this is still something that I still think we should be thinking about. Within this, let me just point out a few things here. So the hospitalization rates that are very slow. So you can see where the big impact is now around the country. So this is not normalized. This is just absolute numbers. So the total numbers around the country. You can see that if we at a federal level, if we need to redistribute funds, some of these states are larger than others, and these are where the resources and things should be prioritized based on the numbers that we're seeing there. However, when you look at the rates within the state, when you normalize it, so you can see which states are being hit relative to the others, you can see that really some of the hotspots now are New York is being hit pretty hard. New Jersey is still being hit pretty hard. Arizona, but a lot of states are now doing a lot better than they were, in terms of hospitalizations. We still are seeing a regional impact, so I can bring this slide up. So you can see that the South still represents almost 50% of the new cases that we're seeing in the United States, which is interesting. We are seeing decreases across the board, but we are seeing more dramatic decreases in some places than in others. All right, and then there are one or two other things I can point out here. No, I think that's enough for now for here. Within the United States, we can turn back to the slides that I had over here. Within the United States, so over 15% now, I have to update it as of the website we just went to. Over 15% of eligible US adults have received at least one vaccine dose. but you can look at the distribution. It varies a lot. So some states have had around 10% of the population vaccinated, where others who are the dark green have had over 15% or far over 15% relative to bring the average to 15%. So you see that there is wide variation across the states. This is based on logistics and the amount of vaccine that's being received by these states, because the states can only administer the vaccines that they're receiving. All right. In terms of the variants of concern, we've talked about the three main variants that people are talking about before: the B.1.1.7 variant, which is the UK variant; the B.1.351 variant, which is the South Africa variant; and P.1, which is Brazil. And so B.1.1.7, you see overwhelmingly is spreading like crazy in the United States, far more than the others. The South Africa, they are increasing. And I've been tracking this week by week. They are increasing, but you can see that there's just a lot more of the UK variant. And the main hotspots for the UK variant in the United States right now are Florida, California, and to a lesser degree, New York. But Florida has around 300, 350 the last time that I checked, in terms of diagnosed cases of the variants. One thing that I have to continue to talk about, and this needs to be updated. One thing that I need to that I continue to talk about is that these are samples, and so around 0.3% of every positive case is tested for the virus's genes, the genetic testing, and so that's a really, really poor rate. And so that means that, and it's been increasing under Biden. I don't know what the rate was. That was as of the end of or the beginning of January, before the Biden administration came in. But if we use that same sampling rate, then that meant that every one positive case here represented 333 population level cases, which means that if there are 1,173 reported cases, then that represents over 350,000 infected people in the United States, with at least a third of them in Florida alone. So Florida, a lot of epidemiologists' eyes are looking at Florida right now, because what happens in Florida is going to be what happens for much of the rest of the country in the coming weeks and months. We know that currently the UK variant is doubling around every 10 days, and probably within around 4 to 5 weeks at this point, to around 15 weeks, depending, somewhere in that range, the UK variant will emerge as the most common infection for COVID in the United States. So it's rapidly spreading. Like I say, all eyes are in Florida. And this is one of the reasons why even people who are vaccinated have been recommended to continue wearing wet masks, to continue physically distancing, and the other things that we talk about. In terms of the variants, so the UK variant is highly protected by all the vaccines that have evaluated it. The South Africa variant is more or less protected. Some vaccines are better at this than others, and the South Africa and the Brazil variant, the P1, hasn't been evaluated very much for the vaccines at all yet. It has a little bit, but not very much. But we can talk more about that if there's interest in a little while. One thing to point out, this question of herd immunity that's come up a lot. So my best estimate right now is that we will not have herd immunity for this disease. That's not necessarily a bad thing, because what that means is that the infection will almost certainly become endemic. And what that means is that it'll become common everywhere. But there's 4 common coronaviruses that we've talked about before that only cause the common cold. And so what this means is that probably the infections will keep spreading, but after people are vaccinated, if the only symptoms that someone gets are cold symptoms, if maybe they could just be asymptomatic, then the epidemic is over. Because if no one's going to the hospital, or not very many people are going to the hospital, then the epidemic's over. There's nothing to really be worried about. And so that's what a lot of us are expecting now, that there won't be herd immunity in the sense that it will stop the infection because we've reached a certain amount. There's a lot of reasons that I presented over the last few months about why this is the case. One of the most recent is Brazil. And so Brazil, there were some towns where they hit 75% of the people in the towns were infected. And then the new Brazil variant came around and a whole new surge came about. And so there's no idea that herd immunity. There's two reasons. One, because of the variants of concern, that there's more variants coming about that will break through any herd immunity. And then the other reason is that we know that people's immunity diminishes over time. And so within around the first 3 months of either an infection or the vaccine, people have the optimal level of immunity. So with the vaccine, so after someone receives their second dose of the vaccine, and then 2 weeks after that, that period after that, so starting at the end of those 2 weeks after the second dose to 3 months are when people have the highest immunity. With natural infection, we found that reduces. So at around the 4th month, around 10% of people can get reinfected. At the 5th or 6th month, around 20% of people can get reinfected. We don't know what the longer term persistence looks like, but it's likely that will continue to drop off over time. So that means in March and April, when the first surge hit, a lot of people were infected back then, and that was almost a year ago at this point. And so that means that there's a lot of people who are now have lost their immunity and now can get reinfected and are getting reinfected. When R is greater, so the surges that we've had are in the context of wearing masks, physically distancing, staying outdoors when we can, staying home when we can, all of these things together that we've been doing over these months, that's the context of the spread. So basically the virus spread as much as it could with those constraints among the people who are not doing it, among the people, and based on the filters that we were putting on, based on the masks and everything else, that reduced the spread. Now it's reducing based on the current context. But this is not herd immunity, because as soon as people take off the masks, stop physically distancing, spend more time in the bars, go indoors, then it's going to be a totally new context, and the R value is going to change back to R naught. And so this idea of herd immunity is something that not very many people are really believing in anymore. Is there anything else here to talk about? I think that's it for now. Why don't we go into questions, Rebecca?
Okay, great. Thank you, Glenn. So Glenn, you spoke a bit about the different vaccines and the protections they offer against the different variants. Somebody had a great question about whether or not the vaccines protect against the new COVID variants better than natural infections. So we see variation, but even with the variation, are the vaccines more protective?
Yeah, that is a really good question. So let me go here first. So I apologize that it's hard to see. The draft of the research paper that I saw this on wasn't very clear in terms of. I mean, the answer's pretty clear, but the figures were not very clear. So
that's why we need you, Glenn. Decipher away.
There's 3 graphs here that we're looking at. The first one, I'll make it a little bit bigger so we can see. The first one, convalescent, are people who are naturally infected. And so now the 3 things, so this is convalescent, all these people were naturally infected. The first one is based on the immunity to the common variants in the United States, not the new variants that are broken out. The second one, B117, is the UK variant, and the third is the South Africa variant. So for the most part, people who were infected the first time naturally, say over the last year or 6 months or whatever they were previously infected, when they were reinfected with the B117, which is again the UK variant, it mostly provided the same level of protection. So mostly protected from UK. However, when you look at the South Africa variant, there was very little protection. And a lot of people who were protected previously were not. In fact, I believe, if I got this right, these are not actually people. They were testing the blood in test tubes, but it's still considered to be a fairly accurate representation in terms of what the likely protection level will be. And so you can see that when they looked at the antibodies, among people naturally infected, there really was not a lot of protection for the South Africa variant, but there was a fair amount, not universal, but there was a fair amount for the UK variant. All right. The Brazil variant and the UK variant seem to be very similar as well as far as we know now. Let me restate that. The Brazil variant and the South Africa variant. South Africa has been studied a lot more at this point. I mean, there's still a lot we don't know, but it's been studied more than the Brazil variant. So we're finding out more information. And the UK variant has been studied the most of all. All right, next on the list is the people who are vaccinated with the first dose. So I'm sorry it's so messy. This is just the screenshot that I took of the study. So this is the first dose. The first dose gave them a limited amount of immunity to the currently circulating virus. But then when you tested it against the UK variant, there was not very much protection, and against the South Africa variant, there was no protection. So that was after the first dose. But we all know we need to get 2 doses. So how does this look with the second dose? So the second dose is here. So the second dose says, okay, here's the common variants in the United States. Next, the UK variant, it was similar. It was like the naturally infected people. It was also very good against the UK variant, but then different than the naturally infected folks, that you can see that it provided a large amount of protection. Not the same amount as the regular variant that was going around the United States or the UK variant, but it provided a fair amount of protection for people with the South Africa variant. This is among people vaccinated with the Pfizer vaccine. You can see, so in contrast, let me make this one bigger again. So people naturally infected do not have the same level of protection against the South Africa variant. So the people who got the Pfizer vaccine with the second dose did have a lot of protection. So definitely get the vaccine, even if you've been previously infected, definitely get the vaccine when you can. Not all of the vaccines are the same in providing protection. What we're looking at here is the Pfizer vaccine, and it's still unclear. We're still figuring them out among the ones that are being evaluated. So Johnson & Johnson, AstraZeneca, Moderna, we're evaluating in all of these, but we do know that there is some level of protection to South Africa with the vaccines, and that level is better than people who are previously infected. So people who are previously infected, if they get infected with South Africa, the South Africa variant, it's going to be as if they just got it fresh the first time without any previous immunity to it. So this is serious. Get the vaccine, everyone. Rebecca, back to you.
Yeah, great. So this is even more research and another compelling piece of data on how important it is to get the vaccine, even if one was already infected. So that's really interesting. Thank you for sharing and deciphering.
And one more thing, Rebecca, to add here that I forgot to mention. So there are 2 main areas that we're looking at with the vaccine. One is the S protein, the spike protein that we've been talking about, and then the other is RBD, the receptor binding domain. But they're very similar in terms of what we're looking at. The first over here is the first dose. The next one is this booster shot, the second dose of the vaccine, and you can see that it has very high levels of immune reaction to the spike protein and to the receptor binding domain. So this is perfect. The second dose for the vaccine is working great. In contrast, when you look at people who have not been either vaccinated or exposed through natural infection, there's virtually 0 immune reaction to those areas. And when you look at people who are naturally infected, you can see that it's very low. It's the same levels pretty much for most people on average to people or less even than people who got even the single dose of the vaccine. So getting the natural infection is maybe like half a dose. It's not even the first dose of the vaccine. It's less than 1 dose. The one other thing that's interesting is that people who are naturally infected develop a ton of different antibodies, not just to the spike protein or to the receptor binding domain, but also to the nucleus protein, the N protein, to other parts of the virus. So I don't think it's the N, but to other, or I don't think it's the nucleus. It's to other parts of the virus. That there's all these different components. The N protein is not involved in the binding with the receptor, the ACE2 receptor. It only becomes exposed when the virus is destroyed by the macrophages and it becomes there. So that's why people who are vaccinated have no antibodies to this. But the N antibody is interesting because there's a lingering concern among a lot of us about antibody-dependent enhancements. And antibody-dependent enhancements have two mechanisms that they're likely to work by. And again, this idea of antibody-dependent enhancements is this idea that the first infection might not be so bad, but if you get infected a second time, then that might actually be the worst one that puts you in the hospital or kills you ultimately, God forbid. And so these antibody-dependent enhancements, a lot of people are paying a lot of attention to. They don't seem to be a big factor with the vaccine so far. However, because people naturally infected also develop these N antibodies, that is one of the main key areas of concern, that they might be at more susceptible risk for the South Africa variant or for other variants that might emerge in the next year. So that's a worry. The other possibility is if the S antigen, the surface antigen that we're looking, the spike protein, mutates a lot, then it might mutate enough that it escapes the current vaccine antibodies, and that too might give an exaggerated response. But luckily, that's not what we're looking at with the vaccines yet. And so if we need booster shots with the vaccine, say in the fall or the winter, then that's something that a lot of people are studying right now. But again, the key takeaway here from this slide is that these N antibodies that have been associated with antibody-dependent enhancements in some studies are only occurring in people who are naturally infected. So people who are naturally infected may be at increased risk, we don't know yet, but may be at increased risk, more susceptible to new variants that become available in terms of the risk of severe disease. All right, now Rebecca, back to you.
Okay, very interesting. Thank you for digging a little deeper there. So we have a question from the audience about folks who've had their second vaccine and if they can avoid quarantining if they are exposed to a COVID-19 patient.
That is a really good question. And so the CDC announced this past week that yes, you can avoid quarantining if you've been exposed to someone, if you've been vaccinated. You should, so they're recommending that people still continue to wear masks and to physically distance and whatnot, even after they're vaccinated. And again, the reason is all of these new variants are circulating more in some places than in others. And so there's still a lot of uncertainty about what that's going to look like. And so that's why better to be safe than sorry. And the other reason is even if someone is infected, or rather, even if someone is vaccinated with the second dose, 2 weeks after the second dose, there's still a small chance that they can be infected. And so even if they don't have any severe symptoms themselves, that's the whole vaccine trials. We're looking to ensure that they don't have severe symptoms. They might still be able to get infected and be asymptomatic and then infect other people around them. And so a follow-on question to this that someone had asked was, well, say you were playing Mahjong, or say you were in a group of people, everyone had been vaccinated in that group. Say there's 5 people, everyone's been vaccinated. It's been 2 weeks after their second dose of the vaccination. Can they take off their masks and drink the alcohol inside and relax and play the games? And the reason that the CDC is still currently suggesting to wear the masks in that situation is because even though none of you in that room are at high risk any longer for severe disease, you could still be passing around the virus asymptomatically. And the problem is, if after the game, a couple of days after the game, or that situation where you've been in that situation, if you go to the supermarket, even with the mask, there's still a chance that you could be then infecting other people. And so the reason the CDC is saying this is because there is a worry now that especially if someone is 70 years old or older or older than their 70s, they tend to hang out with other people of the same age range or same comorbidities. And so if some people who are not vaccinated end up hanging out with other people who are vaccinated, so the vaccinated hang out with the unvaccinated people, even if those people then wear the masks, if the one who is vaccinated is asymptomatically spreading it, it will increase the risk. Even with the masks, it will increase the risk and not eliminate it for the ones who are unvaccinated. And that's the exact reason why they're saying, it's probably still a better idea for the next few months to, even if you're in a group where everyone has been vaccinated, to still continue wearing the masks and whatnot, just to prevent asymptomatic spread among yourselves so that you don't accidentally infect a neighbor who has not yet been vaccinated over this short-term period. So that's the current thinking. But oh, and one other thing to add here. So the quarantine, the exception is so it's fine to skip the quarantine. The one exception is that if you feel symptoms, then they should not quarantine. Or we don't know yet how long the vaccine is going to be protective. And so if it's longer than 3 months, then we need to evaluate this to see if it's longer than 3 months since your second dose of the vaccine, the 2 weeks after the second dose, then we don't know exactly if it's going to be as protective. So we still are going to have to follow up on this. It's likely to still be protective for severe disease. We know that the protection for severe disease is going to likely last longer than the protection from our ability to infect other people. So another way of saying this is that our immune system is really good at protecting our lungs and our heart and protecting us from severe disease, but it's not as good at protecting us from getting infected and potentially infecting others. That's why we can continue to get cold symptoms and spread the cold around. So 3 months, we don't know exactly what it looks like yet. So still we're asking people to take precautions until then.
All right. So we got to still keep wearing at least one mask, maybe 2 masks. I read an article today about perhaps 3 masks. What do you think of that, Glenn? 2 masks is probably enough.
Oh, in fact, I took a picture. Was this it? Yeah, this one was here. So we were talking about proper wet mask wearing, and I just searched under Google for COVID masks, and I was just looking how many of these COVID masks, when you do just a simple search, are wearing them correctly. This person's not wearing it correctly. You can see that the air can escape on the sides and on the top. This person, you can see that the air can be escaping on the side. Whoops. This person also, the air can easily escape on the side, a little bit on the nose. This person, it's a little bit better. You can see that it's indented on the nose, but still on the sides, it's not a perfect fit. So a lot of people, even when you just look at the Google sample, are not wearing their masks well. This person's, it's a little bit tighter, maybe up by the nose. It's harder to make it, there's air, the air can escape. But I would say in terms of priority of how we wear our masks, like, look at this. These masks are almost worthless. They're not worthless. It's better than not wearing a mask. But when you see how much air can escape, whoops, it's hard to make it big. You can see how much air can escape on the sides. The masks are really not doing a good job. So in terms of priority, even with one mask, people should be prioritizing wearing the mask so it's as tight a fit around your entire face as possible. So it should cover your nose and your mouth as tightly as possible. So there should be no air escaping on the sides. It's very common for air to escape next to the nose. It's very hard to get that fit next to your nose. That needs to be the priority. There's bridges, they call them bridges that they sell that you can put under the mask that makes it tighter. They typically also, there's clips that you can sell. Some you have to try different things to see what's the most comfortable. So if these people were to wear a second mask, it's not going to do anything for them because all the air is already escaping on the sides. So you really need to make sure the mask is a tight fit. And if wearing a single mask does that, then that's better than double masking where it's not a tight fit. The double mask is better if you already have a tight fit and now you're trying to make it even another layer of protection. And certainly that's going to be better than one mask. However, for most people I see people all the time wearing masks, even if it's covering their nose and their mouth, it's not totally worthless. It's better than nothing. So for instance, you don't spit out directly in front of you, but in terms of the aerosols and stuff spreading, they can easily escape the sides. So it's not really as helpful as people think.
It's a great visual. I'm glad my picture didn't pop up on your Google search, Glenn. I hope I've been wearing it properly. Goodness gracious. Thank you to all of our models in our presentation today.
Well, people in the Northeast, one way that you can test it is, or any place where it's cold right now or below freezing in the United States, put on your mask and then go outside and breathe in the air next to where there's a light where you can see the fog that comes out when after you breathe, and you can see where the air is leaking out. And so that's a good test to see how much is escaping through the mask.
Great idea. We can definitely do that here in the Northeast. That's for sure. Okay. Any good news on vaccine
Ooh.
hesitancy, or we're pretty much where we've been at?
One other
last
thing
few
that I
weeks.
wanted to share is this. So I've talked before. So we were just talking about masks. Before we get on to the next question, Rebecca, we were just talking about masks, and this is the first. So this past week was the very first commercial that I saw put out by the CDC widespread. And so now the Biden administration came out, and one of the first things that they did was start advertising widely the CDC about masks. So I wanted to just share this because it is so great. All right, first let me make it big. Oh, that's not what I want. Give me 1 second. All right, okay. Now I just wanted to share this, so hopefully it'll play okay.
Oh, it's on. Release the meteor.
He's looking at you, kid.
I dig it.
That felt pretty great.
So my point is, wouldn't this have been great if the CDC was doing this back in May or June? And so I'm really glad that the CDC is now starting to be the CDC that we've come to expect, where they're doing this kind of stuff. It's a little bit premature to be doing it for vaccines because there's not enough vaccines to go around now. And there's a lot of people that are hungry for the vaccines. But in another couple months, another 2 to 3 months, I am quite confident we'll be seeing, or quite hopeful that we'll be seeing similar types of marketing ads put out by the CDC and other organizations for the vaccines. So, I mean, because that's great. This is a public health campaign that I just showed you with the masks. I hope you could hear it okay. But they market test these things. They've been doing public health campaigns like this for decades, for smoking, anti-smoking campaigns, for driving drunk, against driving drunk. For decades, they've been doing this. They know what works, what doesn't. And so now they're doing it, and they're really aggressively spending money on mask campaigns and these other things. So it's the CDC now. I'm very rapidly gaining confidence in what they're addressing our epidemic in the US now.
Glenn, I'm going to pause right there and call on Debbie to unmute. She has a follow-up question about the CDC and mask wearing advice.
Hi, Glenn.
Hey.
So the question is, I mentioned this to you earlier, but my dad is very concerned and wondering why it's taking them so long, the CDC and all the powers that be, to tell us how to wear the masks correctly. It is a huge concern, and obviously you've proved and we know how important it is. What's taking them so long? Yes. Originally, there was a lot of question about whether we even needed to wear the masks at the beginning, and now they're saying absolutely. But yeah, so explain.
So let's revisit what the last year looked like with masks. So originally, back in March, there were 2 reasons why the CDC did not recommend wearing masks, and the 2 reasons were: 1, they were afraid there would not be enough in the hospitals. And if you remember, there were these surges in the hospitals and not enough masks. And so people in the hospitals were reusing masks and they couldn't find enough. So as a result, it made sense that people locked down at home and that individuals who were not in the healthcare field should not be going out and trying to compete with the healthcare facilities to get masks for themselves. So that was that was a good rationale for doing that. The second reason was, back then, there was an open question. And the question was, we didn't know how well masks would protect against SARS-CoV-2 spread. And it's a legitimate question because now we do know now that it's not 100% protection. It's not a yes or a no question. Wearing a mask is better than wearing no mask but staying physically isolated and not going into a large room where a lot of people are there, even if they're all wearing masks, it's not as safe as staying home. And so we didn't want to confuse the message back then and just say wear masks, because we didn't know how effective it would be. That was everything that we've been providing guidance on is based on science and based on evidence. And so it took months for the studies to come out to demonstrate that wearing a mask was better than wearing no mask, because we really didn't even know at the beginning. And when you wear a mask in a healthcare facility, it's typically different than how people wear masks at home. A lot of people that wear masks now with COVID, you might get one mask and wear it for the whole day. Whereas in a hospital, you wear a mask with a patient, take the mask off and see the next patient, put a new mask on. And so you're constantly going through these, and so you're reducing the spread. It's very different with someone wearing the same mask all day long. The other issue over time is that the CDC is still trying to get people to wear any mask. Even forget about if they wear it well or poorly. A lot of people are not wearing any mask at all. So that's the very first thing, getting them to wear a mask. And then among those who are wearing it on around their face, some people wear it like under their chin, some people wear it under the nose. And so even just getting it to like cover the majority of their face is a major issue in the United States right now. So that's where we are. And so there is a spectrum in terms of like how taking people where they are and moving them to a better place. And so for everyone on the call, hopefully, where we know we should all be wearing masks and we're talking about double masking, for all of us, where we're at is to say, make sure your mask fits well. And that's a different message than someone who's not wearing any mask at all. That's why the superhero ad that I just showed you is better for the general population. Because if we were to, that's probably the single biggest thing we could do. If we could get everyone to simply wear a mask like around the area, even if it's not perfect, that will have a much bigger impact at the population level now than anything else. And that's why they prioritize that order in terms of how they're advertising it. But that's where we're at. All right,
All
Rebecca.
right, makes sense. Thank you, Glenn. So we will all stay tuned and be on the lookout, and certainly we will share with you if we see any other interesting commercials come our way. Everyone, be on the lookout and be sure to spread that information that Glenn just shared with us. If you see a friend or loved one wearing a mask that's a little too loose, share what you just learned, because now we too are experts on mask wearing, thanks to Glenn. Okay, so we have a question from the audience about do people who get the COVID vaccine need to worry about getting mammograms or any other types of doctor visits that they are looking to do sort of preventive, not necessarily, doctor visits that are imperative?
Yes. So no, the answer is no, but yes, I have a good answer for this. So the question is mammography imaging impacted by COVID-19 vaccine? So the mammography itself, breast cancer is not impacted, but vaccines in general might stimulate the lymph nodes. And so generally when people get a vaccine, they need to tell physicians who might be doing mammographies about the recent vaccine, just so that they're aware. Because if people have a lymph node involvement, then that could be representation of a advanced breast cancer that's advanced to the lymph nodes, and so that could be a worry. However, in this case, it's just something to be aware of. There were some people, some mammography centers that identified some of their patients as having swollen lymph nodes that were triggering false positives in their tests. So the Center for Disease Control said that more than 11% of vaccine cases lead to swollen lymph nodes after the first vaccine dose. And after the second vaccine dose, 16% of the people received the swollen lymph node that could give a false positive test on mammograms. The symptoms usually appear within 2 to 4 days and then disappear by around 2 weeks. So this is something that they're almost certainly aware of. But the only thing it would worry is triggering a false positive on the test. But so it doesn't have anything to do with breast cancer, nothing to be worried about. It's just an interesting fact. And it seems to be similar to vaccines in general, but this is for COVID-19 because it's the second dose that's really triggering even a higher level that I think people are talking about it. Great.
Okay, interesting. And it's, it was really, it's good to know kind of what to expect from that second dose. I think, many of us are not used to taking sort of a first vaccine and then a booster so soon right after. And so just knowing the potential for those types of side effects, it's just very helpful going into this entire process. I think I speak on behalf of our whole audience. Okay, so let's see here. Moving on, Sandy, could you please unmute and ask your question about masks?
Glenn, thank you, Becky. You mentioned first wet masks. I'm not sure if I heard correctly. And my other question really was, I read an article recently that you can take N95 or KN95 masks, if you should have any, and reuse them by steaming them. I think there were a couple of different ways to cleanse them without obviously putting them in the washing machine, but you could steam them. Could you respond?
Yeah, those are good questions. First, I didn't realize I wasn't sharing my screen, so let me come back to sharing my screen. This is for anyone who's interested. This is the information I was just talking about mammography. So in terms of the questions you had about masks, so actually, the masks that's up from months ago in terms of or weeks ago in terms of the mask use that we were looking at, the different types of masks. The main difference between the N95 and the KN95 is N95 is the standard in the United States. KN95, I think, is the standard either in China or South Korea or I think it's China. And so the worry with the KN95 was that the manufacturing reliability might not be the same as the N95, but I think that for most people in the general population, they're probably okay to either one. In terms of washing it versus not, one thing that's interesting that might be a little counterintuitive is we found that with cloth masks, washing it might actually improve the ability of the cloth mask to filter out the potential virus. And the reason that might be the case is because the cloth fibers, after they're washed, might not be as tight. They might be a little bit more spread out, and so it might actually be more protective after you wash the cloth masks. In terms of steaming versus not, I haven't heard anything about it. I know that the virus doesn't last very long, generally in even just keeping it out in direct sunlight with UV light for more than, say, an hour or so. That's going to be plenty of time if you dry it out and just keep it exposed. The steaming issue, I don't know specifically how effective steaming would be. Yeah, I don't know anything more than that. I mean, these masks are meant to be disposable, the paper filter ones. But the cloth masks, washing them definitely improves it. Or there's indications that the washing the cloth masks improves it versus not. But yeah, I don't know. I can't tell you anything more about steaming.
I'll send you a copy of the article, but thank you very much.
Yeah, I'll look into it. Thanks. Rebecca, before
Okay,
you go on,
yes.
at some point, we have maybe another 10 more minutes. It might be nice to ask one of the questions about New York long-term care facilities. I know that there was something else that erupted this week and there's a controversy, so I could spend a few minutes going into that. But I know that there are a bunch of other interesting questions this week, so you can tell me where you'd like to focus.
Okay, right. Yes, we're just about at the top of the hour here. So yes, let's talk a little bit about what's been going on in New York. And then this question came up a few weeks ago, and it would be interesting maybe to end with the question about the Apple Watch.
Oh yeah, sure.
Yeah, so let's go to New York, come back to technology, and then we'll wrap up from there.
Okay, great. So New York long-term care facilities. What is going on here? We hear a constant thing, Cuomo did it wrong, Trump did something wrong. What's going on in New York? So I've spent a little time looking into this. We know that New York and New York City were hit among the earliest states really hard. So New Jersey, New York, a bunch of states in that area were hit really hard back in March, April, May. And so let's dive into this. There was a lot of concern at the time that New York was underreporting the number of deaths in the nursing homes there, the long-term care facilities. And then there was also a worry of whether Cuomo exacerbated the epidemic early on by sending nursing home patients back to the nursing homes after they were in the hospital, but potentially still contagious. So let's dig into this. So when you look at these fact checkers, these are opposite fact checkers. This one is the Kaiser Family Foundation, who said that Cuomo forced nursing homes to accept COVID positive patients. And Kaiser is saying that's mostly false. Cuomo wasn't as bad as people are saying, is according to Kaiser. Here's PolitiFact that's saying that it was Trump's guidance, the CDC guidance, saying to put the cases back in the New York long-term care facilities, and it's Trump's fault. And PolitiFact is saying that's mostly false. So they can't both be true. Let's dig into this a little bit more and see what the heck is going on. All right, so the CDC did provide guidance, and the guidance was very clear. So let's say specifically what the CDC's guidance was back in March of what this was in place by March 23rd or so. This was 2 days before New York gave its guidance. And so the CDC's guidance had two parts. The first part was, is the patient medically ready for discharge to a long-term care facility? And medically ready meant that they were stable, that they were no longer ventilated, that they were stable and did not require to be in an emergency situation or intensive care unit. That's the first part. The second part was that was the long-term care facility that they'd be returned to, were they able to safely care for a patient recovering from the virus by implementing all recommended infection control procedures? So there were these two parts. The first part was the patient ready to be discharged. The second part was the long-term care facility ready to receive the patient so that they would not have an infectious spread. When Cuomo first released his guidance, he claimed was the exact same guidance as this. First, he said the CDC was recommending that long-term care facility patients who were stable should be returned to the long-term care facilities, and that was consistent with what the CDC was saying. And second, that he said that he sort of left out this part about whether the long-term care facilities should take all the patients. Later, and months later, he said that it was common knowledge and it was state policy that any long-term care facility should only accept patients if they were able to implement all infectious control procedures. That was what Cuomo was saying. Some facilities, long-term care facilities in New York, claimed that they felt pressure to take the patients regardless of whether they had the infection control procedures in place. So legally, I don't know what that would mean. According to the law, there was pre-existing requirements, regulatory requirements for any infectious disease that long-term care facilities only take patients if they are able to. And this was consistent with the CDC's guideline. But let's dig into this a little bit longer. The CDC was clear. So for this first part, that whether patients can be discharged to long-term care facilities or kept in the hospital, the first part was clear. The CDC was recommending that they go back to long-term care facilities where they were able to. They were definitely, and if you recall, back in March or April, and so I have all these slides that we were looking at, back in March or April, whoops, that's not it. So this is New York. Back in March or April, the number of hospitalizations, did not do what I wanted to do. The number of hospitalizations in New York, not California, which just came on the screen because the ghost just did something, but New York, which is hopefully about to appear. Slow computer. All right, let me skip New York. And here what we're looking at are excess deaths. All right, New York. Okay, here's what we're looking at New York. New York, back in March and April, had hospitalization rates that were growing dramatically. Look at the shape of this curve versus the shape of other curves that we saw earlier on. So here's the US as a whole. The shape of the curve was not, it's pretty sharp, but you can see that it's been a lot slower for these other surges. In New York, in contrast, it was a sharp spike. And so every day there were 1,000 more patients going into state hospitals. And so we knew because a couple weeks earlier, that in Italy and other places, the hospitals were being overrun. And so what that meant was that there were no more hospital beds, there was no more oxygen. In fact, that's what we're seeing in some parts of Brazil now, some other countries now currently. If you get to the point where there's no more hospital beds, and people even without COVID who might have a heart attack or just get into a car accident, if there's no place for them to go because there's no hospitals, then the number of deaths starts to skyrocket way more than COVID. And so we knew back then that we needed to get as many people out of the hospitals as quickly as possible as we could. And so that's why the CDC provided their guidance to get the patients out of the hospital as fast as they were stable and as fast as the long-term care facilities were able to take them. So now the issue was some of the long-term care facilities took them without necessarily being ready to take them. And so the question was this Cuomo's fault, or was this the long-term care facility's fault, or was this the CDC's fault? And so based on what I've said, you can say, according to regulatory requirements, it was the facility's responsibility. According to the New York's guidance, they were not clear, and so it might have been perceived that it was a requirement by the state to take them at all costs. The other thing to bring up here that's really interesting that I like to say over and over again is that among severe cases, they are no longer contagious within 10 to 20 days after their first symptom. And so that means the majority of people within 10 days after their first symptom, even if they are shedding virus, so the virus, like virus fragments, even if they're shedding virus fragments and are triggering a positive COVID-19 test, they are no longer contagious within 20 days, and the majority are no longer contagious within 10 days. So even if a lot of these people were going back from the hospital and being sent back into the long-term care facilities, that doesn't mean that they were still contagious. Even if they were having positive SARS-CoV-2 tests, it doesn't mean that they were still contagious. So that's another tricky thing in terms of evaluating this. Finally, in terms of now the second thing that's been of a concern is underreporting. So let me come back here. And so the average number of deaths in long-term care facilities versus outside of long-term care facilities were on average around 42 or 43% back in March and April. It's been improving, and now it's closer to 35%. New York was an outlier, and they were reporting that they had around 20 to 25% of their deaths in long-term care. Now they've updated their numbers, and now they're saying it's closer to 39, 40%. That's the most recent based on the new numbers that they just reported this week. But 40% is roughly the average of the country. So it means New York was not different in a meaningful way from any of the other countries who got hit early on. Pennsylvania had 52% of their deaths, COVID deaths, occurring in long-term care facilities. Rhode Island here, 65%. New Hampshire, 71%. Maine, 54%. New Jersey, 35%. But similar to New York, that might also be underreporting a little bit. But the key takeaway here is that New York is not an outlier in terms of having a lot of excess deaths from these long-term care facilities. If anything, they're right smack on average with the updated numbers that they just reported. So in terms of the big picture here, New York did nothing differently than the vast majority of these other states that we're looking at. Even North Dakota, Minnesota, the states that got hit over the summer or the end of the summer, more recently than that, they also are at 58%, 63%. So in terms of New York's culpability, their numbers do not look meaningfully different than any of these other states in the country. So in terms of that culpability, you would have expected if there was something New York did wrong, that their numbers would be higher than the average. And their numbers are not higher than the average. So that's one key thing that I'm interested in looking at. The other thing is when we look at the excess deaths, I have a slide for that too. So the excess deaths. So the total number of excess deaths at this point are around 570,000 in the United States. This is again, total excess deaths versus the average reported over the previous 5 years, previous to COVID-19. That's a lot. When you can look at just New York City and New York alone, pardon me, it's slightly over 50,000, so around 52,000. So that means under 10% of the total deaths in the United States were in New York. So it's higher than we would like, but it's not a huge outlier. Because if you recall, when we look at the shape of the picture in New York, that first, here it is, when it was right at the beginning. Why is it giving me error messages? Let me go to New York. So when we look, it's not letting me for some reason. But so this was United States as a whole. When you look at the shape of the curve, that crisis back in March and April, we didn't know what was going on. And so New York was in a fog of war type of situation, as was New Jersey, as was Connecticut, as were all these states being hit really hard back in March and April. And so we can give them a little slack. That's very different to the second surge in the summer, where we already had months of experience at that point, and there was no excuse for their undercounting the misdiagnosis and for the long-term care facilities. There was less of an excuse back in the second surge, and certainly in the third surge, much less of an excuse now, because we've had many, many months of experience working with it now. So when you look at the states that I was just looking at, like North Dakota, Minnesota, these states that have had continuing high levels of deaths in long-term care facilities, there is no excuse for that because they got hit months after New York, New Jersey, these other states that over here, and they should have learned their lesson. So my where I stand, just my high level on New York is that New York was in the fog of war. I can't blame them as much as other states later on, the later surges. When you look at the total numbers, they aren't doing worse than the average for the country. So we can't really criticize them for being worse than the average in the United States. For the reporting, they did mess up. They underreported significantly, and data integrity for epidemiologists, in law, in legal terms, perjury is considered a serious offense, and it's serious enough that it can send people to jail. Among epidemiologists, if people don't have data integrity, if they fudge their data or they're not reporting data accurately in significant ways, they're doing it on purpose. For an epidemiologist, that is as bad as you can be as an epidemiologist. That is significant enough that people would lose their career, they would lose their jobs if an epidemiologist fudged data. So that's a significant issue that New York City that New York State rather was fudging their data. That's a significant issue. The ultimate question of whether the CDC provided guidance about whether long-term care facility people should be put back in long-term care facilities, that indeed did come from the CDC. There was the two parts to it, not just that they should be prioritized to be putting back as soon as they are able and they're medically stable, but the second part was ensuring that the long-term care facilities were able to take the patients. And that was according to regulatory requirements in place. Whether they were actually up to that standard, it seems like there is some disagreement there in terms of whether the facilities should have agreed to take all of them. And that's why we have the different fact checkers saying different things. Anyway, I hope that answered some questions there.
Yes, it did very much. And we're glad that we have you as our fact checker. And we're really glad that we can count on your data integrity because this has definitely been a hot topic of conversation. So thank you. Before we jump and conclude with this Apple Watch segment, which is very interesting, could you just clarify something that you said earlier? It sounded like you said something about a wet mask. Did you mean to say wet mask, or did that just come out in that way?
I did not mean to say anything about wet masks. In fact, just the opposite. If you soak your mask in water and then try to wear it, you're not going to be able to breathe through it. So don't do that. I
Okay,
don't, yeah, I
got
don't know
it.
what I was trying
Okay.
to convey. It's
Just
hard
wanted
talking
to
just for
make-
an hour. It's hard just to talk so long. So
Well, trust me, I'm been used to hearing you talk for a really long time, but that's good. We like to hear what you have to say. Okay, thank you for clarifying it. So should a mask become wet, then in the converse, you would recommend that folks remove the eye mask and put on a nice dry mask. Okay, good. Thank you for clarifying. Okay, let's wrap up with the Apple Watch. Tell us what you use the Apple Watch for in this context.
yeah, so it's fascinating. So it's actually not just Apple Watch. It's been reported on Apple Watch a lot, but Garmin and Fitbit, a lot of these fitness trackers on the hands have been doing similar studies. And what they've proven at this point, the evidence is very strong, is that these fitness apps on the Apple Watch, the Fitbit, the Garmin, all of these are very good at predicting whether someone has COVID-19, is infected with SARS-CoV-2, even before they have symptoms, which is fascinating. And so this is great. Hopefully at some point it will be useful. The problem is there are currently no apps available to do this. So just because it's been proven in a medical study that it could work, it hasn't been released as any publicly available app at all. So that means that right now it doesn't do us any good. It might be ready in time for, I don't know, 6 months from now, a year from now, if there's any worry or another outbreak of some kind. But for now, there's no available app to download. Fitbit, Garmin, they're not set up to do this. So it's more an academic study. It's interesting, though, that it's been proven that it can work. So I'm really hoping that some apps are developed and validated soon, because it's going to be important once the apps are released that they are validated. And we actually do a new study that demonstrates that whatever app is produced is as accurate and reliable as the original study that was done. You can't just do an app and say, oh, this is like the study that was done. No, we have to redo it, retest it, make sure it's every bit as accurate and reliable. Those apps are not currently available. So it's an academic study. It's interesting, but not useful right now in terms of the real world.
Interesting. All right, something we will definitely keep our eye on. Who knows, right?
But you know, I mentioned, if you recall, 6 months ago or longer, I shared with you the dog studies that were being done. And those two, whether the dogs could smell COVID-19 even before a test. And those were also positive. Those were academic. But now since then, they've started to be used in different situations. And there are dogs in real life now around the world being used to screen people for COVID without the COVID-19 test. So it's great. It's an early proof of concept.
Absolutely. All right, get your devices ready. Glenn will let us know when there's an app for that. Okay, we will end with that thought. Thank you to our audience. Thank you for being so engaged as always. Thank you for sending in so many wonderful questions before our conversation, during our conversation. Please keep sending those questions to Glenn or to me this week. And we look forward to seeing you same time, same place. Everybody have a happy and safe and healthy week. We'll see you next Sunday. Thank you, Glenn.
Thank
Thanks,
you.
Rebecca. Thanks, everyone. Have a great week.